All right, so in this section, I'm going to share with you some clinical cases. I have 3 cases to share with you. Let's go over the first case. So the first case is a patient, she's 40 years old, and this is a patient that I first saw when she was in her mid-20s. We went through a lot of care and management together to help deal with her Hashimoto's and other blood sugar issues and a whole list of things. And then we became friends over the years. And then I get a random email, and this is what the email says. And she lives in Sweden. I have been in Sweden and returned to California the 20th of March. Something is really effed up with my hormones and or thyroid. I've had severe migraines in September, October, November, and early December, and vomiting before my period. The migraine stopped mid-December, but then I started with hot flashes. They came out at 30, 60 minutes intervals, day and night, lasting about 1 minute and followed by freezing. January, the hot flashes let up, and I got a normal period February 4th. After that period ended, the hot flashes returned and have been ongoing ever since, with no new periods that should have started around March 2nd. In conclusion, when I have hot flashes, I get no period. When I have no hot flashes, I get a period. I'm going nuts because I haven't slept sound for weeks due to restless nights of sweating and hot cold spells. So you can see she's going through what looks like a hormone fluctuation, maybe even perimenopause pattern that's starting to show up. Notes: Monday 11 through 26, migraine with BARF, 100% bad. December 18th, migraine with BARF, 80% bad. Hot spells every 15 minutes. Spotting started next 3 days. Should start regular cycles on the 4th. And then, again, headaches get worse throughout the day. Breast ache, drops of blood sugar, lots of swellings and cravings, and then light pink blood spot. You can see that on different days. And then basic hot flashes, light spotting, and migraines. So this is an immediate red flag. So these are what we call the red flags of premature ovarian failure. So the interesting thing with her is she has a family member who's an acupuncturist. And, you know, the key thing is when you look at the type of infertility patient at this point, is she's only had an alternative medicine evaluation. I haven't seen her in 10 years in a clinical setting outside of once we helped her manage her chronic condition. And we remained friends, so I got this email out of the blue, but she hasn't really had any formal fertility evaluation. She's concerned about her fertility. She wants to have children, and she recently broke up with a long-term relationship. And looks like she's got some dysmenorrhea, maybe even amenorrhea that's happening. She then visited a alternative healthcare practitioner, and since her hormones were messed up, they ran a urine test. And this is the results of the urine test. And if you take a look at the numbers here, you can see some red flags right away. You can see that her progesterone levels are in the postmenopause range. Her estradiol levels are in the postmenopause range, and estradiol, progesterone, postmenopause range. In general, testosterone levels are within normal reference range. DHA is within normal reference ranges. The cortisol profile, for the most part, appears to be within the normal circadian rhythms. Little bit of imbalances there, and then if you look at her, most of her hormone levels, they are either below. The progesterone metabolites are below the luteal range. Estrogen metabolites in the urine are in the low end or within luteal ranges. And most of the things are in the low end stages there. So her cortisol profile showed some levels in the low range. She was diagnosed with an adrenal stress syndrome, and the thought process was that her adrenal glands were not functioning well, and they were going to just support her adrenal glands, and that was going to be the answer. So that doesn't make any sense to me, but this is what the evaluation was. So for me, and for the material that we taught in this course, adrenal bounces are not uncommon, but they're not going to totally shut down ovulation and cause, premature or hot flash symptoms and perimenopause symptoms. So the working diagnosis is possibly with her at her age. Does she have premature ovarian failure? Does she have perimenopause? So I go, listen, when you come back into California, go get a routine blood work. So we ran this routine blood panel just to see what's going on with her. And I'm really concerned about FSH because I want to know if she's starting to enter menopause and any just overall general health. Glucose levels, hemoglobin A1C were all normal. Chemistry profile was all normal. Thyroid panel was all normal. Now here we have some problems, and this is what I was worried about. If you look at LH, her luteinizing hormone levels are 44 and ranges between 77 to 58.5 indicate postmenopause. If you look at her FSH levels, her levels are 44.2, and then you have to look at the postmenopause range. She's in the postmenopause range. So this now we've got either premature ovarian failure or normal menopause. So she's 40. So most people get into menopause around age 50. Anything below 35 and 35 to 40 is premature ovarian failure range. So does she have any ovarian antibodies? So we checked Cyrix-Ray-5, no ovarian antibodies. And at this point, it's okay. She went back to Sweden and go, you got to go to a fertility clinic. It looks like you're in menopause. You got to see if you have any eggs left, what your ovarian reserves are, because that's what it sounds like you're at. It sounds like you're in perimenopause. So estradiol levels, FSH levels were confirmed again to be in the menopause range. Look at her AMH levels. AMH levels, which are a marker for ovarian reserve, less than 0.7. So she's down here in the red. So normal is above 1, and her levels are less 0.7. So she's in the loss of ovarian reserves. So she's age 40. Statistically, you can see these things start to go down. Her levels are going down sooner than normal. So she's got a little bit of premature ovarian failure. So this is the case where the clock is ticking, and this is to the point where, it's almost over as far as her ability to have ovarian reserves. So if you kind of take her workup and take her history and background, and if I go through the checklist just as an exercise, she doesn't have any BMI issues. There's no issues with psychological stress, lifestyle, environmental, medical conditions. Now, she does have a severe inflammatory condition. She has a genetic skin disease that causes significant inflammation. And it's possible that significant inflammatory response may be a factor why her ovaries went into premature, maybe borderline premature ovarian failure because she's 40 years old age. But we also know she had some little slight patterns of hypoglycemia that she was dealing with as far as lifestyle symptoms. At the end of the day, she has egg impairment, ovarian eggs quantity and quality, and she's getting to the point where has dysmenorrhea, amenorrhea, and she's lost her cycles. So we look at her tissues and look at the things that are involved here. Basically, we're dealing with ovarian follicle failure or ovarian follicle depletion in the follicular phase. So my recommendation was work with your fertility clinic if you want to have kids. See if they can get any eggs extracted, see if they can freeze them, and see if you can do IVF therapy. So I wanted to share this case with you because this is where end of the line of fertility looks like. This is the point where you've lost a window of time. And this goes back to making sure that you get the diagnostic workup. Now, here's what I have a problem with this case. She has all these symptoms of early perimenopause. Her hormones are messed up. She gets diagnosed through a urine test that she has adrenal disbalances, and if they can fix her adrenals, maybe they can come back. And if she were to continue with that, she may have completely lost any potential chance to pull out any healthy eggs that are left so they can freeze them and maybe potentially give her the option of IVF therapy down the road. This is what I meant to say earlier. When the talk is clicking, especially when patients get older, there is no time for incompetence. You have to figure out what's going on and make those appropriate choices. So that is example number 1. Now let's get into example number 2. So case number two is complex, okay? And in case number 2, the key things with this fertility presentation is there's infertility. The patient has had a formal male fertility and female infertility exam, diagnosis of unexplained infertility to some degree, diagnosed with PCOS, but that's not been thought to be a major part of the infertility because it's very minor according to them. So you have some patterns with dysmenorrhea, and those are the presentation of the patient. Now look, she's 29 years old. So in this scenario, she's 29 years old. She's taking nature thyroid in the morning, which makes you suspect she's got hypothyroidism. She's been diagnosed with PCOS to some degree, given metformin. She's taking lots of digestive supplements, and this is a case study in your course material. And Pamela was very generous to let us use her case and have some follow up with her with a video that I'll show you in a second. But let me give you some background with her case and some of the things that she's went through here. So these are questions that I ask in a case review form. So when I'm working with new patients, I have a list of questions. I send them in before we have the patient fly out and do a workup with them. And this patient is from Mexico, and she ended up having spent some time in San Francisco, and I was able to spend some time working her up. And the third patient is, by the way, from the UK. So we have an international group of patients in this case study section here. But she's had some pretty good workups in her home country. But at the end of the day, her main complaints are unexplained continuous weight gain and inability to lose it. Now, I got to tell you, like, she's not obese in any kind of way. She actually has a healthy body mass index, but for her, she felt like she was heavier than she wanted to be. She wasn't her ideal body weight for her, but you wouldn't look at her and go, she's unhealthy in any way. Irregular periods, inflammation in the body, puffy face and eyelids, fluid retention, can gain 2 to 5 pounds in a day. When people that say they can gain 2 to 5 pounds a day, that's metabolic. That's electrolytes. That's not necessarily body fat. So there's some electrolyte swelling, body fat, hormone imbalance issues that are taking place that are causing these fluctuating fluid retentions where there's a 2 to 5 pound difference throughout the week. Facial hair, that's screaming PCOS, especially on the neck, jawline, and chest. Cold intolerant, that may be thyroid. We're not sure. She is on nature thyroid. Hands and feet are always cold. Just highlighting the key points. 2010, she was diagnosed with hypothyroid, but when you look at all the lab results, it's not clear that she actually was hypothyroid. It looks like she was working with some healthcare physicians that just weren't sure what to do, and they felt she may have a thyroid issue and placed her on replacement. She started to gain weight even with thyroid replacement. She started to go from one grade to the next. At this time, she was also placed on birth control pills in December. This is back in 2010. 2011, she went abroad to Australia. Her period stopped in 2011, and she says, and I have never had it again during my stay there. She continued to have puffy eyes and swelling and symptoms, and still on thyroid medication. And then later in 2011, her thyroid levels were checked. Everything seemed pretty okay. She continued to have fluid retention, mood swings, acne, cravings, PMS symptoms. And then as we get into from 2011 to 2012, actually at the end of 2011, she went to her gynecologist back home. She wasn't menstruating at all. She was analyzed. She was found to have some ovarian cysts. One of them was 2.7 meters long. So they decided to put her on some medication, birth control pills at that point. And that was it. 2012, she out of desperation to feel better, changed her metabolism. She started working with some nutritionists and healthcare professionals. She was given a low-calorie elimination diet, completely gluten dairy-free. The nutritionist felt that she may need to do an ACG diet. She started the ACG diet, lost a bunch of weight. ACG diet, you basically get ACG therapy, human chorionic therapy. And then you eat less than 500 calories a day. She did that for 21 days, lost weight. It all came back once she went back to normal calorie. In September, she decided to see a new doctor. They went through the whole list of things. They thought she was crazy and wanted to give her Prozac. She went back to switching from medication nature thyroid to Uriox. And then at that point, she went to Synthroid and went back and forth thyroid hormones. She was then prescribed spirulactone, which is like an anti-androgen medication. Her thyroid labs were constantly within normal. This is the first time her lab tests were elevated 9.09. Other than that, all her lab tests have been normal. I think this could have been a false error. false marker. So she's basically struggling with thyroid battles, trying all these different thyroid meds. Her doctors keep thinking she has an underlying thyroid issue. They keep changing her dose. They keep changing her replacement. 2013, she writes in her case report, that's when she read my thyroid book and started to think that maybe she should just improve her overall health and try to balance her system, and maybe she has some reverse T3 issues. And she was still having her periods were still missing in January. She had hormone levels checked all the time. She had no antibodies ever show up with her thyroid test. 2013, she's seeing more and more doctors doing adrenal tests, diagnosed with adrenal fatigue. She's dealing with amenorrhea. And so she's basically going from one doctor to the next, all with different theories. She's gone to see an endocrinologist. The endocrinologist told her it's all in her head. There's nothing going on. One endocrinologist said it's PCOS, put her on metformin. Didn't seem to make a big difference with her overall health. And as you can see, each year, she's continuing to exercise, follow a healthy diet, do everything right. 2014, she went to see an acupuncturist nutritionist focused on health specialized. She tried homeopathy. She tried doing a fat fast for 5 days. She tried a master cleanse in 2014. 2015, she was having severe bloating and burping symptoms, went to a gastroenterologist. He was told she had irritable bowel disorder, given some medications for that. She was given Prilosec. She then decided to do the clean protocol to try to support her gut. She ran glucose and insulin panels, all within, nothing that was significant. Everyone's confused about what to do. She went to an OBGYN gynecologist specialist fertility. She was concerned that she wasn't getting her periods back. She would basically try to use Provera for 5 days to get her ovulation going. Those things didn't work. She went to another endocrinologist. And at the end of the day, it's just confusing and not knowing what to do. Then her life gets more and more stressed out. She's having lots of ongoing metabolic issues. Her health is not doing well. She started working with the functional medicine people. They order some Dutch testing. They order some lab tests. They try to put her some nutraceuticals. In 2017, she gets an IUD inserted. She gets married. She gets some dental work done. She goes to see another functional medicine doctor. At that point, at some point here, they remove the IUD. She gets married. She's still having health problems. She ends up having ongoing GI issues. They move to San Francisco. She goes to school to study to be a nutritionist, and she ends up becoming a very talented and brilliant nutritionist. So she starts looking at her diet. She tried some keto diets for about 2 months, wasn't 100% strict with it, and then tried some intermittent fasting, 16-8 protocol, wasn't that strict with it either. And then 2018, she tried the fast mimicking diet. She went to see an acupuncturist. She tried a bunch of Chinese medicine. And then she did some hair analysis with another doctor, and she goes through a list. And this is like a file where it's this thick. And I'm just trying to summarize some of the key points, okay? But this is how chronic patients are. And as time goes on, you can see, she started to then develop some dizziness and some disequilibrium problems. Her symptoms were getting worse and worse. She went through a whole list of medications and support. And she ends up in the last page of this summary, which I want to read to you, which kind of summarizes everything. This is right before I saw her in my office. And this is her complaints during my visit with her. She reports that today I'm the heaviest I've ever been in my life. She's 142 pounds. Every attempt I make to try to lose weight gives me the opposite effect. Overall, my health problems are not an issue to live normal life. Nevertheless, it is very exhausting and frustrating going to one doctor to another and trying to find out the root cause of my problems. Instead of getting better, I start developing some new problems. What keeps constant and what is my main concern is that ongoing weight gain, around 50 pounds this year, and the inability to lose weight. I've literally tried everything to lose weight, and only the opposite happens. The only way for me to lose a little weight is to go on an extremely low-calorie diet for a long period of time. But once I eat something else, I'll just go and get all the weight back and more. The other way I had managed to lose weight is by taking prescription diet pills, which I know will only do more harm. I take them without significant success, but once I decide to stop this year, gain a little weight back and some more. As I mentioned, I'm studying to become a holistic nutrition consultant, so I'm very conscious of what I eat and try to eat mostly low-carb, paleo, organic, whole foods. I'm very active and try walking everywhere, work out 5 to 6 times a week, mixing Pilates, yoga, bar, HIIT, running, spinning, cardio, and weights 1 time a week. I'm also concerned on my PCOS. I'm planning on getting pregnant next year. My periods have never been regular. This year, by eating nutrient dense, good quality food, I managed to get my period almost every month, but I believe that I'm not ovulating. The past 2 months, I've taken my basal temperature first thing in the morning. It's always around 97.07. I thought that by increasing my thyroid meds, I was going to be able to increase my basal temperature, but that didn't happen. I've also seen an increase in my hirsutism. I've seen stop the spirolactone. I thought that by getting rid of IUD, that would get better, but it didn't. I've tried every single fad diet, a lot of diet pills, body wraps, reductive massage, body creams, all kinds of exercises to try to lose weight. My mind is always wandering on things I have to do in order to lose weight. It has become an emotional issue as well. It's hard to comfortable with what I am. So if you look at the list of practitioners she's seen since 2010, 1, 2, 3, 4, 5, 6 endocrinologists, OBGYN, MD acupuncturist, 7 endocrinologists, MD nutritionist, 8 endocrinologists, functional medicine practitioner, another nutritionist, another acupuncturist, another MD nutritionist, and an otoneurologist. For 8 years dealing with this. Okay? Abnormal menstrual cycles, abnormal hormones for 8 years. She's taken natural thyroid, magnesium, basically every single supplement you can think of. She's been diagnosed for hypothyroid, metabolic syndrome, ovarian cysts, insulin resistance, birth control pills, toxic overload, gut problems, parasite, the whole gamut of things. So these are the labs. So for me, when I work up a patient, I want to get a very detailed history with them. And her case review history that she sent back to me was 30 pages. Okay, so I'm summarizing it. And in my practice, if I don't get a thorough case review back, I don't even go any further. If they gave me a 2-page case history back on their case, I go, we're done. There's no point, because I know they're not serious. Whenever I get these complex cases with detailed histories written, I always know that they're serious. And if they're serious, I'm serious. If they're not serious, what's the point? So it's always nice to get that detailed information. This was one of the tests they did. So she was in Mexico. And not that I know how to speak Spanish, but you can translate these pretty quickly here. So she had a glucose tolerance test where they gave her a glucose load. Within 30 minutes, within an hour, within 90 minutes, she started at patterns of insulin resistance. Her glucose levels were elevated. And then 1 hour and 30 minutes, she had hyperinsulinemia. These are the things you see with PCOS type responses. She's already been placed on metformin. She's already been placed on androgen blockers that didn't seem to make much of an impact. She has abnormal lipid panels. Total cholesterol is 260. Her TSH levels have been within normal reference ranges. Her LH levels, FSH levels are within normal reference ranges. Her prolactin levels are normal. Her progesterone levels are normal. Her total testosterone levels are normal. She had a Dutch urine test done. Nothing really showed up abnormal within it. She has a little bit of abnormal circadian rhythm with urine. DHEA was on the low end. Androstenedione was a little bit high. Estrone was a little bit above that range, but nothing really significant with that. And for the most part, most of the panels within the normal reference range is nothing that can be identified with that. And then just some cortisol levels above the reference range. Glucose levels on this lab test show 78. So she has postprandial insulin resistance, but her fasting glucose is low. That's the common thing you'll see with PCOS patterns. And she's not obese. So this is like an atypical pattern. Now for me, I summarized her case after I got a chance to review all her files and look at that the long history. And this is what my conclusion was after working her up. So she had 10 main complaints: weight gain, inability to lose weight, dysmenorrhea, hyperlipidemia, constipation, facial hair growth, poor circulation, frequent urination, dizziness and headaches, sensitive to light, and mood swings. And she wanted to try to have, when I saw her, it was right when she got married, and she wanted to get pregnant in the next year. and she wanted to know how she can do that. So I wrote here, Pamela's a 29-year-old female nutritionist with a chief complaint of inability to lose weight and a long list of symptoms associated with polycystic ovarian syndrome. These symptoms include irregular periods, fluid retention, frequent urination, facial hair growth, and weight gain. She also has a family history of hyperlipidemia with cholesterol 269. She has never had lipid electrophoresis testing conducted to determine if her hyperlipidemia is a genotype. There's a long history of episodes of fatigue, depression, lack of motivation, hypothyroid symptoms. 2010, it appears that her doctor inappropriately diagnosed her with hypothyroidism with normal laboratory ranges of TSH at 2.7. This time she was prescribed Nature-Throid at 2 grams daily. At this time, she did not have her thyroid antibodies tested. In 2011, she became amenorrheic. At this time, she did not have any menstrual cycles. She had significant premenstrual symptoms such as fluid retention and mood swings, acne, cravings for sugar. During this time, her doctor performed an ultrasound and was diagnosed with multiple ovarian cysts. In 2011, she had a replacement of her breast implants due to capsular contraction and has not had them inserted in 4 years. 2012, she visited a new doctor that switched her medication from Nature-Throid to Uterix, and she has been prescribed spironolactone. She had a repeat TSH test with TSH of 9, and her doctor confirmed the diagnosis of hypothyroid. However, these lab test measurements were made after a rebound of being off thyroid replacement, and the accurate diagnosis of hypothyroidism is still suspect at this point. 2012, she went on an HCG diet to lose weight. She was getting daily injections of HCG on a 500-calorie diet. She initially lost some weight but gained it all back within 4 months. 2013, she was working with a new doctor. She had TSH measured. The results came back normal with a TSH of 0.3. At this time, her TPO and thyroglobulin antibodies were tested and found to be negative. She had thyroid checked again and was told she did not have antibodies to her thyroid. It was diagnosed with polycystic ovarian syndrome by her endocrinologist in 2013. She was prescribed metformin and phentermine and spironolactone. Despite following the protocols taken Bravera, she continued to have some form of amenorrhea. Throughout 2014, there's a spelling error, Pamela tried various fasts and cleanses and maintaining a low carbohydrate diet. She was complaining of gastrointestinal symptoms, bloating, burping. She had consultation with the gastroenterologist and prescribed irritable bowel disorder, prescribed Libitum, Prilosec. In subsequent months, she found a new dietary regimen to improve gastrointestinal ecology and took digestive enzymes, probiotics, oregano oil. She stopped her medications prescribed by her gastroenterologist. 2015, Pamela had an opinion by another endocrinologist. She was told that all the thyroid tests were normal, was also diagnosed with PCOS. 2006, she tried various natural supplements to support her hormones in combination with taking thyroid medications, metformin, and spironolactone. She had an IUD inserted and tried various diets and nutritional approaches to support her health with no significant outcomes. 2018, she had her first episode of dizziness and pressure in forehead, lasted 15 minutes. She had repeated episodes of dizziness, and she went to see an OT neurologist, was told that her symptoms were likely due to hypoglycemia. Family is recently married, planning to get pregnant next year, but is concerned about a polycystic ovarian syndrome. She's had noticeable facial hair growth and is still suffering from lack of ovulation. So my initial goal, once I got a chance to work her up, my initial goal was, number one, initial goal of management would be to improve her glucose and insulin patterns that demonstrated in the postprandial testing. If menstrual cycle is not normalized after blood sugar and insulin surges are managed, further support to establish ovarian pituitary feedback loops may be incorporated. Once the PCOS syndrome is managed and regular menstrual cycles occur, the goal of therapy would be to optimize prenatal nutrition care and further evaluate any other persistent symptoms. If you guys notice, if I cut and paste some of my soap notes, you'll see a spelling error here and there with my dictation system. Lifestyle recommendation. Regular exercise routine has been recommended to reduce fasting insulin, improve insulin. She's already exercising all the time. The key component of her impact, these metabolic parameters, and then basically recommended she try a ketogenic diet. Here's my lab test with her. It did 2-hour glucose tolerance test, and the glucose tolerance test at 2 hours came back extremely low, almost pretty much hypoglycemic. So she's getting this blood sugar roller coaster ride. She has no reactions to gliadin. Her lipid panel is still showing elevations. We did another glucose tolerance test a month later. Her glucose levels are still hypoglycemic. That wasn't a false test on the first one. We checked with insulin and glucose. We did a third test a month later. Glucose still, she's getting hypoglycemic an hour and a half. She's getting a massive surge of blood sugar dropping patterns right around an hour and a half. Okay? So at this point, my conclusion was Pamela's clinical findings are patterns associated with PCOS. Her levels are fluctuating all over the place. She's getting this massive hypoglycemia. This syndrome is associated with altered metabolic dynamics, leading to difficulty losing weight. And then she had some circulation issues, and we found that she had some cerebellar dysfunction causing her dizziness and vertigo. But the key point was really to try to go after the PCOS type pattern. So at that point, I put her on a ketogenic diet and put her on some nutraceuticals to support her fertility. This is the protocol that I did with her. Put her on a modified ketogenic diet. I put her on some AMPK stimulators from glycoprotein. These are Apex products. I put her on products to improve her insulin resistance. I put her on products to support her gut short-chain fatty acids with glucose control. I put her on Megaco3. I put her on resveratrol. And we had her follow the ketogenic diet. So Pamela has been in ketosis for 3 months now. She's been monitoring her levels with urinary ketones. Before she did this, she wasn't really monitoring her levels very well. She has not lost any weight. She has not noticed any change in energy levels. She has noticed that energy levels are better. Her sugar cravings are better. Her last period was 10 minutes late. 10 months should be, 10 minutes, 10 months late. She's not seeing any improvements in her facial hair. She's having a hard time falling asleep. She has lots of breast tenderness during her recent menstrual cycle. When she did a 2-hour post-manual test, she had significant blood levels of dropping. Further questioning about her menstrual cycle identifies that she typically has food cravings, acne, bloating, and fluid retention before her cycles. At this point, it's clear that her insulin surge alone may not be the only issue. Further testing needs to be done, so we wanted to make sure we haven't missed anything. As a matter of fact, interesting, her testosterone levels were found to be a little bit low. Remember, these levels fluctuate. Her FSH spiked up a little bit. This is a 30-day salivary test we did with her, and her progesterone, estrogen levels were all okay. But look at this. Her average testosterone throughout the month, not an isolated test, was extremely high. So this really confirms, even though she's having some hypoglycemic spikes, she's getting some of these PCOS patterns. And those high androgens were suppressing her FSH and suppressing her LH. So it is definitely a PCOS-related pattern. The rest of her blood chemistry panels look normal. She went and did another Dutch test on her own. Everything there seemed within normal reference ranges. We put her on a protocol to try to deal with endocrine receptors. We checked her chemical exposures. She didn't have any pesticides or chemical exposure at that point. We just continued to focus on her insulin resistance and PCOS pattern. This may take months to reverse PCOS. It's not going to happen within a short period of time. So this is in June. So this is now about 5 months, very aggressively supporting her insulin and managing her PCOS. 30-minute follow-up is conducted. She has not lost weight. She has had a 4-day cycle. Her estrogen has not gotten any better. She's not having any energy levels. Skin overall health is not improving. She says she does know that her energy levels are much better. Her skin and overall health has improved significantly the past year following the blood sugar management and ketogenic diet. Pamela stated she would like to consider pregnancy this year. We decided to evaluate endocrine disruptors and pesticides, which I just showed you, and we start to put her on biotransformation support. Now, then we get into August. Her menstrual cycles are finally normal again. So after about 7-8 months of managing her insulin-resistant ketogenic diet, she starts to finally get into normal cycles. And this is important because when you look at these complex conditions, you can't get a change within sometimes 2 or 3 months. You have to keep pushing it. If you know that's the mechanism, which was very clear that was PCOS, we have to keep pushing it. And once we got her menstrual cycles normal and her insulin and blood sugar levels normal, then in October, we get a follow-up with her. She's been pregnant for 30 weeks now. She's still having some blood sugar issues. And this case really points to the fact of how important it is when you see PCOS and blood sugar patterns to continue to push that pathway until you get some change in your normalized cycles. So it took about several months here to finally get her cycles to normalize. The first thing that changes was her energy levels start to get better. She started to have a little bit more energy and feel better. Her mood started to change. And then eventually her cycle started to become consistent and normal. And here's a recent update from her just last week. Okay, hey Pamela, how are you? 30 weeks pregnant now, right?
I'm pregnant. I'm 30 weeks pregnant. Thanks to a lot of thanks to you. Well, a lot of part of it.
Yeah, thank you for sharing your case with everyone. And so let's kind of go through some of the the basics and kind of go through your journey. And obviously, there's lots of factors in the infertility, the male factor, female factor, and so forth. And it first started when we connected together, and at that point, you have a long history of seeing all these people and doing all these things, but ultimately, the first thing was you didn't really have healthy cycles, or you've lost your cycles for a period of time. And can you kind of talk about that first, like your experience with your menstrual cycles, and you were in your late 20s.
Yes.
How old are you now? It was a couple of years ago.
I'm 31. Yeah. I worked
29 when I saw you.
Okay, yes, like 2 years ago. I approached you because I've had a history of all of these hormonal imbalances. I have hypothyroidism, and I was diagnosed with PCOS, insulin resistance, and everything that you can think about. I had it. So I knew I wanted a more functional approach and to get really to the root cause of the problem. But my main issue was my periods were not regular. I didn't have a regular cycle. So I was starting to think of getting pregnant maybe in a few years. I knew I had to work this and manage this before I started trying. So that's when I got to you. And I've tried everything before. Like, I tried the pill and other drugs and progesterone and synthetic hormones, basically. And nothing worked long term. Like, I had a period maybe for 1 month or two, and then I didn't have one for 2 or 3 months. And then again, it was on and off. And my insulin resistance was, I had a really peculiar type of blood sugar imbalance because I was doing everything correct. Like, my lifestyle was actually really healthy. I was working out. I was eating like a whole foods diet, a low carb diet, kind of. I was doing everything that I was supposed to be doing. So when I got to you, you did a complete workup and then checked like everything. And we started on a ketogenic diet.
Right. I remember talking to you and going, listen, Pamela, this is PCOS. This is an insulin battle. And I remember you at beginning kind of being skeptical and not really sure and frustrated. Tell me more about that.
Yes. Okay. So, I got the diagnosis of PCOS, but a long time ago, but I didn't even understand what was PCOS. And I didn't even understand the complexity of PCOS, because I think it's one of the more complex conditions there is, because there are so many factors and people think it's just an ultrasound and that's it, and you get the diagnosis. So I was like, I think I'm fine with that. It's not that. One of my main issues was that it was really, really, really hard for me to lose weight. And I also had like a lot of male, symptoms or hair growth here, and then different things that I knew they were part of the PCOS, but I don't know. It was different. My case was different. I wanted someone to tell me like really what was going on, because I didn't fit into the regular criteria of what you read.
Right. And then for me, you were eating very healthy. You were a nutritionist. You knew how to eat healthy food, and you understand all the concepts. So I remember, your labs are your labs. Like, you have to go with it. And I remember then we had to do a very aggressive approach for your insulin. And we decided to go for get you in ketosis, and we put you on a bunch of supplements, and we went from there. So can you share that experience?
Yes. I think I was on a ketogenic diet for maybe 6 months. It actually didn't help me lose weight, which was my first concern.
Yeah.
But it reversed completely my insulin resistance. I was having a lot of symptoms that I never related to insulin resistance. And now that I know, it's like, of course, it's obvious. I was having frequently urination. I was waking up at the middle of the night. I was tired after eating. I was like all this insulin resistant pattern. So when I changed my diet into a ketogenic diet, everything improved. It took time. It was really, really frustrating, because I remember after like the 2 months of starting, I went for a checkup, and you were like, your body should have responded better than it did. So because I was taking all these supplements. Maybe I remember I was taking like 16 pills each meal. It was like intense, but I trusted you because I was desperate, and it took time. And then you had more labs done, and you switched the protocol. I kept on a ketogenic diet. You told me to increase fiber because I might have like maybe a lot of hormones accumulated in my body. I needed a detox because of all the previous doctors and protocols that I've been on. So my body was not responding as it should have. So after, let me think, after 6 to 8 months, my period was just like a clock. I had my period every month. I wasn't having those symptoms. My brain fog went away, which I never thought it was about that. I was having like a really weird pain, dizziness. I don't know. It was something that I never attributed to that. My thyroid improved as well, just as part of like a side effect of this. And I remember also having I was more ready to start trying to get pregnant. So you told me before you try, I wanted to do another test, and you sent me a toxic core test, which I don't know if it exists anymore, but because I heard you say, I think it's a different one.
Yeah.
And because it's also a main thing. And then,
well, just to stop you right there, I think just for people, I think the goal was first to get your menstrual cycles back to normal because you have no chance of pregnancy without a menstrual cycle. Yes. And then it was like, okay, now let's look at reducing risk factors so you don't have any issues with your development of your child. And then we did a toxic effects profile, which just checked for compounds and pesticides, and you were pretty healthy. I mean, you've done a good job with everything. So that's kind of where we were. Now, let me ask you a question. With your menstrual cycles, you've always had difficulty with your menstrual cycles for how many years before you got them established again?
Sorry, okay, that was a good question. My first menstrual cycle was when I was 15 years old. I mean, I was older than the average. And then I just had one and then nothing for a year. And then it came back at 16, but I was never regular. And then they put me on the pill because the pill fixes your hormones. Supposedly, of course, it doesn't. And I think everything went south there. Like my thyroid stopped functioning correctly, and then my insulin resistance increased, and then I had like a lot of things tried on me. Yeah. And I never got my period back. I was on the pill for maybe like 4 years, and when I stopped the pill, I didn't have a period for a year and a half. And then I was put on the pill again to get my period, which doesn't make any sense. And then I was on and off for maybe 2 more years. And then I decided to stop everything. And that's when I went and see you. So, so maybe like 10 years or.
Which is good for people to hear, because sometimes, you hear if someone hasn't had normal cycles for 10 years, that's hopeless, but it's not. It's just you have to work through it. Yeah. Okay. So then I remember we had a discussion, and we're like, all right, you don't have toxic levels, your menstrual cycle's back. You should be fine to try to conceive. And can you remember that?
I remember perfectly that day. It was actually August last year.
Yeah.
And no, I think 2 years ago. Yeah. And you were like, okay, you're ready. Now you can try to and start trying and planning for a family and everything. But remember, getting pregnant takes time. It's not as easy as everybody thinks. It's just be patient. It can take a lot of time, and it's fine. It's not that you have something wrong. So that helped me a lot, because it took me 9 months actually to get pregnant. It's another story that I can tell if you want, but that message like resonated on my mind, and it was like, okay, be patient. It takes time. It's really hard. I mean, if you think about it, it's really hard. It takes like a lot of precision and everything to just get pregnant. So yeah.
Right. And then you went had a fertility workup. There's nothing wrong with you. That your husband got a fertility workup. They found low sperm.
Yes.
And then you found out he was hypothyroid, and then you kind of got involved and really helped the
Yes,
whole thing. So there's a male factor part of this as well.
yes, completely.
Please tell us about that.
I mean, every doctor that I went always told me like, you're gonna have trouble getting pregnant. Don't worry, you can come and we'll give you treatment. And that's the conventional part that I didn't like. And I was like, why are they telling me at 15 years old that I'm not gonna be able to get pregnant in years? So I always thought it was going to be my responsibility or my part of the problem. And then when we started trying, and we didn't have success, maybe 3 months, I was like, okay, I told my husband, let's get some lab work done. And because he had a varicocele when he was a teenager, so I knew that something could have been like could be, I don't know, affecting. So I also had his thyroid checked because I see a lot of patients as well, and it came out that he was hypothyroid. So we started working with another functional medicine here in Mexico. I'm from Mexico, and after maybe 6 months or 4 months of fixing his thyroid and getting him on a lot of supplements and a protocol, a fee protocol, just to say something, we were able to conceive. We were already considering the treatments. We were patient, and now we're almost ready to be parents.
Yeah, it's almost there. Exciting.
So, yeah, we're almost there.
And you had the struggle of trying to find a thyroid doctor that knew what they were doing, and fortunately found a good functional medicine practitioner, and you were.
And it's so hard. It's really, really hard, and I'm not a doctor. I'm a nutritionist, and I practice functional medicine, but from my scope.
Yeah.
And it's so hard getting a doctor to work with me that has the same approach. And I actually found one that has also been in your modules and your courses. So we have the same approach, and that's who I work with.
And surprising, your husband's TSH was, you were saying, in the 5 range, like completely obviously hypothyroid, and it kept getting ignored. And it's like, why would that happen?
And it was ignored by an urologist, by a OBGYN, by like everybody was like, no, his thyroid is fine. That doesn't affect fertility. And it just didn't make sense. Right. So I had to dig in. And I mean, I think of course, it's not only the thyroid, it's a lot of factors, but that was the main thing that helped.
Right. Fantastic. So anything else do you think it's important for clinicians to know through your perspective, having a background in functional medicine and also going through this, as a patient? What would you share?
I mean, in my case, I think it's very important to start seeing both male fertility and female fertility at the same time. Mm-hmm. Because what we see usually, it's like, okay, they start with the female, and after maybe 6 months of trying or something, okay, now let's look at the male and see if there's something wrong with him. And it's also a very emotional period, and it's very frustrating. And so people really want to know what to do. I also think that there's a lot of in conventional medicine, there's a lot of people that abuse the use of fertility treatments. I mean, it's great that they exist because a lot of people get pregnant through them, and if not, maybe it will be really difficult. But I think that there's a lot of things to look into before just like going straight into a fertility treatment.
And you were pressured to do IVF constantly, right?
On the first appointment, like I've been trying for 1 month, and they were like, no, you're not getting pregnant with his semen count. You're never going to get pregnant if it's not an IVF. And I decided not to believe, like I chose to change doctors. I saw another opinion. And then of course I did my own research and kind of practice. And I mean, I was empowered, and I know a lot of stuff, but a lot of people don't, and they believe everything they hear. So I think it's a great responsibility, not responsibility, but great opportunity, us functional medicine practitioners, to spread this message that there are many, many, many factors that affect.
Sure. And right now, for your prenatal care, you've been on multivitamins and minerals and taking lots of fish oils and omega oils and so forth, right?
Yes, but I also so, I mean, they never told me that on my regular prenatal appointments.
You knew as a nutritionist to do those things.
I knew, and that's why I see a lot of patients on that, but it's really hard to get them to get some lab tests done. For example, the thyroid, I think it's really important to check it throughout the pregnancy, because then you get this postpartum Hashimoto, and and everybody thinks that it's the baby blues, but maybe there's a thyroid thing going on. So it's a different approach, but I think it makes more sense.
Well, congratulations. We're looking forward to pictures in a few, weeks.
Yes, of course. I'll send it. My due date is Christmas Day, actually, December 25th. So, yeah, I'll send pictures to you. Thank you so much for being a big part of this.
Thank you so much. Okay, Mike's good. All right, so this is a great story, and we're so lucky to have Pamela share a case with us. And she's actually practicing as a nutritionist in functional medicine in Mexico. And at this point, she's really become an expert in infertility. So it's just wonderful to see that. Now, when you look at her case, you can see that she's got PCOS patterns that were a key thing that was involved there. So why after all these years, after seeing 8, 9 endocrinologists and 20 practitioners, did she not get care? Because PCOS is complex. Unwinding PCOS takes some time. We actually had to she tried a ketogenic diet before, but she didn't measure ketones, but to actually make sure she was in ketosis. All the principles we talked about in the Karazi Institute diabetes blood sugar course of breaking down the vicious cycle, we had to employ to make some change with her. Then once we got her cycles normal and things were looking good, we had to go through and make sure she didn't have any endocrine disruptors and check her pesticide and chemical levels, and all those factors were pretty healthy. And there was a male factor component to her case, to the couple's case, to her and her husband's case, where he had low sperm count due to hypothyroidism, and unwinding that whole pathway was what's led them to, a pregnancy. So she, when you look at her case, she also had some subtle issues, some microbiome issues, some biotransformation issues, and really working into unwinding this web was a key factor. And just as an exercise of going through the checklist, when you kind of go through it all, she had a lot of environmental workload. When I saw her and she was going through her courses in school, she had a mixed pattern of insulin resistance and hypoglycemia in her lab work. She had endocrine imbalance of ovarian egg physiology with her androgen issues, her PCOS. There were some environmental factors that may have been impacting her eggs. Her menstrual cycles were abnormal, and the male factor part of this endocrine imbalances, thyroid impacting sperm health, were part of the big picture of the PCOS pattern. So kind of went through getting her normal cycles normalized, optimizing her health, and then now she's taking lots of essential fatty acids and healthy nutrition. She has removed all her major risk factors just through practicing a healthy lifestyle and eating really well and keeping her blood sugar under control for pregnancy complications, for risk of childhood developmental disorders, and for maternal postpartum issues and so forth. So basically at the point where she's really going through each of these steps, and excited to see pictures of her child. Now let's get into case 3. So case 3 is a case, first of all, it's a 43-year-old woman. Her chief complaint to see me was she flew in from the United Kingdom. She had infertility and multiple miscarriages, hypothyroid symptoms despite normal blood tests, insomnia. She complained of anger and irritability, water retention in her legs, lack of libido. She's currently on Nature-Throid, metformin, and progesterone cream. Her current supplements are vitamin D, selenium, probiotics, adrenal support, CoQ10, B5, trace minerals, reishi mushrooms. So anyways, this patient was a 43-year-old female with In the United Kingdom, throughout her childhood, she suffered from multiple throat infections, including laryngitis and tonsillitis. When she was 33 years old, she was diagnosed with hypothyroidism. Then in 2017, when she was 43, she was finally diagnosed with Hashimoto's. She reports she has symptoms of hypothyroidism that started when she was 10 years old, with symptoms of feeling cold and suffering from fatigue and insomnia. 2010, she was diagnosed with polycystic ovarian syndrome at age 35 and with endometriosis at age 40 in 2015. So she's got a combination of both of those. Chief complaint is infertility. She has been pregnant three times, twice in 2010, one in 2012. All three pregnancies ended in miscarriage. The last two miscarriages occurred after 10 to 12 weeks. Since 2012, she's not been able to get pregnant. She has engaged in several rounds of IVF treatments, but her viable embryos did not hold after they were implanted. She was diagnosed with PCOS, but it's not been managed really for this condition. So she's taking the standard approach. She's taking metformin, and she's got Hashimoto's. And just the fact she's got thyroid antibodies for autoimmunity never being addressed, and all she was handed was the pill for metformin, but without any blood sugar support, and then rush into IVF therapy is a problem. So remember, with miscarriages, and her body mass index is up. She's not severely obese or anything, but she has an elevated BMI. Her elevated BMI, thyroid antibodies, ongoing PCOS, active, untreated, unmanaged, inflamed endometriosis, or all completely ignored, and then rushed into IVF therapy. And after 3 miscarriages, she's trying to seek some help. So when you kind of look at the type of fertility patient she is again PCOS patient, failed IVF, and she actually has endometriosis also. Failed IVF, wants alternative medicine approach, and infertility due to repeat miscarriages. So if we go through the checklist, we can go through and kind of look at some of the factors involved with her fertility. So we have high body mass index, work environment, work overload, stress, lack of physical exercise, doesn't exercise much. She has regular exposure to air pollution where she lives in the city. She has endocrine imbalance impacting ovarian egg and physiology. You can circle androgens of the PCOS pattern. She has a hormonal imbalance impacting her healthy cervical mucus. And she has infrequent periods. And she has this whole PCOS androgen infertility pattern and patterns that may be throwing off her menstrual cycles. When you look at her labs, her glucose level here is at 107. And then her TPO antibodies are positive. So now we know we have some insulin resistance patterns, and we have some thyroid antibody issues to deal with. The rest of her lab work doesn't seem off. She seems within normal ranges there. And look at testosterone. Testosterone is normal. So you guys have to remember, testosterone levels will fluctuate up and down. They could be in the normal reference range. That's the key thing with PCOS. You're not always going to see it high all the time. And then another follow-up test that was done a little bit later found TPO antibodies, again, constantly high. TSH is low because she's on thyroid medication. So this is my impression of Anna going through this case. It appears that Anna is suffering from a pattern of subclinical insulin resistance associated with patterns of polycystic ovarian syndrome, Hashimoto's, hypothyroidism, and she had some early signs of cerebral degeneration. Previous laboratory tests have confirmed Hashimoto's, hypothyroidism with elevated TPO antibodies. She's currently being managed properly with thyroid hormone replacement, meaning her TSH normal range. Although she has been prescribed metformin, there seems to be ongoing patterns of dysglycemia associated with clinical symptoms that include changes in energy levels after meals, nocturnal hypoglycemia, episodes of anger and irritation. These patterns are typical of insulin surges, which activate testosterone. It's also likely that her periods of insulin surges may be leading to testosterone fluctuations that may disrupt normal female hormone cycle physiology and leading to patterns associated with polycystic ovarian syndrome and infertility. So we went through and tried to stabilize her blood sugar levels, tried to get her on a ketogenic pattern to break her out of this vicious cycle of insulin resistance. And our initial goal was to get her in ketosis and see if her energy levels improved. Her energy levels are more stable. If we can get her menstrual cycles to improve. Remember, we're still in step 1. We're just trying to get her menstrual cycles to be normal. Manage her nocturnal hypoglycemia, reduce her inflammation. And before we even started the protocol, look at her blood glucose. This is while taking metformin. So she had her initial evaluation done. Let's see what year this was. It was like a year ago. And then I did some updated lab work when she flew into the UK. And her fasting glucose was 185. Her hemoglobin A1C was 5.9. So that means her blood sugar levels are not being controlled. She's at this point diabetic, not just insulin resistant. We know she's got the whole Hashimoto's antibody patterns. And I ran some Cyrex Array 5 to see what's going on with the rest of her autoimmunity. So besides TPO antibodies, you see some alpha-beta tubulin synapsin. I don't like to see neurological antibodies because that increases the risk for infertility issues. And we did a follow-up with her a little bit later, and then she notes that she has been annoyed with the ketogenic diet. Her ketone levels show levels of trace levels of ketones. She has lost about 2 kilograms of weight. And then she goes through and talks about her diet. And for the most part, just to kind of summarize, because we're running out of time here, what happened with her is she never really got into ketosis. She had some patterns of being ketosis. And the next part of her pattern was to increase her physical activity. And I'm telling her, like, listen, you have no chance of getting through step 1 of these 8 steps until you get your insulin under control, get your blood sugar levels down. If you're not doing any physical activity, you're not going to be able to change. Let's get you in ketosis, get your inflammation down, and let's get you to move. And at that point, she felt the diagnosis was incorrect, and she stopped care. And I wanted to share that case with you. Because I know without doubt, if we had some time here, she still has some ovarian, we could have made a big difference for her. So I showed you 3 different types of cases in this case study. I showed you one where you can see what premature ovarian failure looks like, which you want to act before that happens. Second case with Pamela, you can see how long it takes to unwind ketogenic diets, and you really just have to stay on track and consistent. You really need a highly motivated patient. And then case 3, where we had a patient that didn't get immediate results, couldn't really put enough change in the lifestyle to make any change, which means we have really no chance. So 3 failed IVF treatments, not willing to really get into full ketosis with their diet, not willing to do exercise, just things are not going to happen. And that's the reality of clinical practice with infertility cases. I always like to show cases of the good, bad, and the ugly. Because that's what we all see in real practice. And anyways, so those are the case studies I wanted to show you. What I want to jump into right now is just a review of all the main concepts with the infertility course, and then we can go into questions. So let's just do a quick review here. And let me get this up.